Good morning, good afternoon, and welcome to Transforming Chaplains celebration of Spiritual Care Week and to today's webinar, Mental Health Chaplaincy, What We Know and Don't Know. I'm Andrew Andrusko, Project Coordinator for Transforming Chaplaincy, and we are all delighted you could join us. Some housekeeping instructions off the top. This webinar is being recorded. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions for our presenter by typing your questions into the questions pane of the control panel that's located on the side of your screen. You may send in your questions at any time during the presentation. We will collect these and hope to include them during the Q&A session at the end of today's presentation. With that, I'd like to introduce Chaba Salaji, Director of Transforming Chaplaincy.
Hello, happy Spiritual Care Week. Thank you for joining us as we celebrate. I'm Chaba Salaji, the Director of Transforming Chaplaincy. We have a few webinars this week to explore the theme of chaplaincy and mental health. We are also excited to start the new Chaplaincy and Mental Health Care Research Network during Spiritual Care Week. And follow the QR code and the link on the screen for more information. It's my pleasure to introduce today's presenter, Angelika Zollfrank. Angelika is a board-certified chaplain, an ACPE certified educator, and an ordained clergy with the Evangelical Lutheran Church of America. She serves at McLean Hospital, which is a psychiatric hospital affiliated with Harvard Medical School in Boston. And in her role, she provides spiritual support appropriate to the spiritual orienting systems of patients, families, and staff. She leads the mental health clinical pastoral education program at McLean Hospital, and she specializes in how spirituality and religion may be useful for coping with mental health struggles. And Angelika also serves as the co-convener of our newly formed network for chaplaincy and mental health care. And again, if you follow the QR code and the link, you can find more information about this network that aims to advance the integration of chaplaincy and mental health care through the care continuum. Next slide. We are also excited to offer some book discounts during Spiritual Care Week. You can use the discount code on the screen to buy a copy of Transforming Chaplaincy, the George Fitchett Reader, which really a great overview of George Fitchett's research over the decades, and the collection offers an ideal introduction to spiritual care research. Next slide, please. And we also have a discount for to purchase the Evidence-Based Healthcare Chaplaincy, a research leader, which again provides a great overview of research, and it's a perfect primary text for healthcare chaplaincy research courses, bringing together key articles from peer-reviewed journals in one student-friendly format. We are grateful to the publishers for providing these discounts. As well as if you have found our webinars and resources valuable, please consider supporting Transforming Chaplaincy. Again, just use the QR code to get to our donation page. Thank you, and I'll turn it over to Angelika. Thank you for being here today.
Thank you very much, Chaba, for your introduction. It's really lovely to be here, and thank you for all the work you have done to also help stand up the Mental Health Chaplaincy Network. I hope people will join it. So we'll jump right in and take the next slide. I would like to begin with a case. This is a woman that I will call Eileen. Not her real age. She was, let's say, 39 years old, Roman Catholic woman. She was readmitted to McLean's trauma unit, which is a unit where mostly women are treated for post-traumatic stress disorder. Her particular diagnoses included also dissociative identity disorder, major depressive disorder, anxiety, and a functional neurological disorder, as well as increased suicidal ideation. During the first admission, so this was a readmit, and in the beginning of the second admission, the team asked chaplaincy specifically not to be involved to avoid exacerbating the functional neurological disorder and also the PTSD. That's actually quite unusual for us in our context, and it was helpful for me to understand why the functional neurological disorder really meant for Eileen that her brain was unable to send and receive signals properly. And there was a disconnection in the function of the lobes and emotional processing. So since that is a big part of what chaplains do, and her memory, concentration, cognition, and the processing of sensations were affected, it didn't seem like a good idea to involve the chaplain at the time. She had a history of sexual abuse by clergy at age 3, and she was currently experiencing what she called demons, and in that sense had spiritual religious struggle, which was interpersonal and as well as demonic. Next slide, please. So zooming out a little bit, the literature on spirituality and mental health is really vast. So I'm just going to focus on a few key points. Integrating patients' religion and spirituality into treatment can improve outcomes, particularly for depression, anxiety, suicide, and general sense of well-being. We could also kind of guess quality of life, although we don't necessarily use that term in mental health. Religious and spiritual struggle is related to mental illness symptoms, to decreased mental illness symptoms and poorer prognosis, and the collaborative religious spiritual coping style. So one where the patient feels like they're collaborating with God or a higher power, has a positive impact on coping. Generally, and overall, positive and negative religious and spiritual experiences are really quite complex in how they impact mental health struggles, and the levels of religious and spiritual comfort associated with greater symptom reduction, particularly in depression. In one study, religious and spiritual struggle was positively correlated with worse mental health at discharge, but that seems to be an outlier study. Next slide, please. So in terms of spirituality and mental health, the satisfaction with religious and spiritual care related to better treatment alliance. So that's actually a really important point for chaplains to know. And when spiritual religious needs are persisting, they precede a decrease in treatment compliance after discharge as well. A notable outcome, as we want to align ourselves with the team and their treatment plan. Patients appreciated individual religious and spiritual conversations, and they liked being in an environment that presented or represented a religious or spiritual environment that was familiar to them. They also liked to be in contact with their religious and spiritual network. Next slide, please. 50% of patients rated all but one religious and spiritual engagement as mostly or completely appropriate, and they endorsed collaboration of process-oriented approaches, which is really nice to hear because that is a lot of what we do. Use of religious scriptures, sharing of treaters' own religious and spiritual beliefs, meditation exercises with religious or spiritual imagery and language were less welcome. And this was quite a sizable sample of 230 patients who were asked. And half of them rated the strategy mostly or completely appropriate. So just to return to that fact. Next slide, please. What are patients' views of mental health chaplains? Well, patients liked to be encouraged in their self-reflection. They liked having a space to speak about religious and spiritual issues without being pathologized. That's a big one in mental health. And they were also appreciative of just simply feeling valued and loved. Connecting with community and with God furthered a sense of belonging, and they were also helped in finding hope. A big part of our work in mental health as chaplains, as is true in the medical environment, is that we help people process loss, grief, and guilt. In this particular sample, which is actually from the UK, this study, patients were also involved in religious services, and they liked that. And overall, there was also a relief in eliminating the need for a faith healer, which is not a small aspect of what we can do in mental health as well. Next slide, please. I don't think I need to talk to this particular group very much about Joint Commission, except that we do have a mandate to evaluate spiritual needs, beliefs, values, and preferences, and there's a whole list of questions that goes along with that. Next slide, please. In terms of perceptions of care, it was important that patients' dietary and cultural needs were met. That's key, particularly on locked units. Prayer times were not always assessed for and provided for, which is important for us to be mindful of and keep working at. Same is probably true for dietary needs in terms of kosher or halal food. Mindfulness and compassion-focused therapies, which are often based on principles that are understood to be Buddhist, may or may not resonate with all patients. And yet there are quite a number of therapies who draw on mindfulness. Psychiatric and surgical inpatients actually showed an equivalent levels of religious and spiritual care, and 81% of surgical patients and only 24% of psychiatric patients contacted their religious leader. So there is something about connecting with a religious leader when a person is struggling with mental health issues that's really kind of significantly lower. And yet we do know that many patients connect with their religious leaders before connecting with a therapist. That's a really interesting finding as well. So the numbers seem to decrease. And there is, of course, quite a stigma in religious and spiritual communities, at least in some, particularly when a patient needs to be treated on an inpatient psychiatric unit. Next slide, please. What are the attitudes towards mental health chaplaincy that professionals have? So in this sample, again, this is from the UK and actually quite old. 92% see the importance of the spiritual dimension, and 25% only considered referring to chaplaincy. It reminds me also of Carl Furlan's study about the different specialties in medicine, and psychiatrists are the least likely to draw on intrinsic spirituality or have a religious orienting system in that sense. So they're therefore least likely to refer to chaplaincy. An integration of chaplains in the assessment and management of individual cases is actually overall rare. But there was more understanding that geriatric patients may appreciate a chaplain, and that's probably true throughout the continuum of care. Next slide, please. In terms of barriers to chaplaincy care, the team's concern is that clinicians fear that they themselves or the psychiatric unit might be seen as proselytizing or introducing bias in some way, even they worry that they might be seen as coercive or intrusive in any kind of way. And of course, patients struggling with mental health issues are very vulnerable to that kind of influence, I would say. Religion and spirituality can complicate treatment. At least that is what clinicians worry about, particularly when a patient struggles with obsessive compulsive disorder, with psychotic symptoms, and also with PTSD symptoms, as was true for Eileen. 11% think that there's no therapeutic value in involving the chaplain, and overall there is a sense that the team feels protective and they are focused on clinical objectivity to the exclusion of religious and spiritual issues. And also they lack an understanding of chaplaincy training. So to continue to inform people about that is important. Generally, there may be, so in this sample it was 11%, negative connotations with the chaplain or clergy, also because so many of our patients have really experienced quite significant religious or spiritual harm. Teams may also want to avoid stress for the patient, and they have concerns that feelings of guilt or judgment may actually be exacerbated. There's a worry that there's a conflict or an interference with the program of care. And then lastly, and I've seen this as well, as I'm sure as people have seen this in the medical context as well, that patients can use religion defensively to avoid treatment. So let's go back to Eileen. Next slide, please. Eileen actually was in this second admission on the unit for a week already, and she decided by herself that she would attend the spirituality group. This is a spirit group that is run using Dr. David Rosmarin's protocol, which is basically a cognitive behavioral approach to a spirituality group. And initially, the team was quite concerned that this could be triggering for her, but she decided to participate, and the chaplain intern who ran the group let me know that she actually did quite well for herself. So this was then communicated to the team, and the team began to wonder, what are Eileen's beliefs and how are they different or the same from her parents' beliefs? The social worker was mainly working with Eileen on staying grounded as to not exacerbate symptoms of PTSD and DID. So that was the main focus. And there was also a sense that there needed to be a priority when there are so many different mental health diagnoses. Then they are addressed one by one, with the most urgent one having priority. So the functional neurological disorder had priority over PTSD and spiritual and religious struggle. So therefore, the postponement of chaplaincy involvement initially made sense. But when Eileen was a part of the spirit group, she actually brought up her spirituality and her faith with her social worker. And so the first step was for the social worker and the chaplain to consult and to begin to talk a little bit more about the religious background, the beliefs, the demonic beliefs, the exorcism that actually Eileen had experienced as being implemented by her family, and also cultural considerations that came into the picture. So we consulted and we spoke at length about Eileen. And next slide, please. And of course, the role of the chaplain, I don't need to say much about that either in this particular context. So let's go to the next slide. It's important to communicate in some ways the code of ethics that we hold ourselves to across disciplinary boundaries, so that people understand where we come from. I think when we do our work, it's fairly clear to the teams, but it's also important to communicate that. And in addition, of course, it's also important to remind the treatment team that about 20% of patients are now nuns who don't have a community clergy who could come and visit them, in addition to the stigma that is often associated with an inpatient stay that keeps clergy away. Next slide, please. So what are patients' views of what a good chaplain is? This is again a UK study. So this is what patients appreciated, that the chaplain was non-judgmental, honest, approachable, genuine, kind, friendly, confident, that the chaplain had life experience, was down to earth, understood the mental health system, and also was a person of God. Patients wanted the chaplain to have spiritual training and to be a religious or spiritual leader. They wanted to know that the chaplain walked with God, had a prayerful life, and had a genuine relationship with God, bring the word of God, and also had the ability to represent multiple faiths as well, channel the grace of God, and bridge between inpatient unit and community. Next slide, please. So who needs a chaplain? This is mainly a study with older adults, and here 77 to 83% said that late life anxiety and depression made them want to have religious and spiritual care be part of their treatment. There were greater rates of religious faith and affiliation, and the engagement with religion and spirituality led to positive religious coping. Next slide, please. 73% of patients in addiction treatment programs in the US are very familiar with spiritually based elements of the 12-step programs. So that's a high number of addiction treatment programs. So the chaplain would actually be a welcome part of the treatment team. 12-step programs themselves can be seen as spiritual communities, as we all know, and 84% of the studies show that faith played a positive factor in addiction prevention, but also in recovery. The numbers are actually quite staggering when we look at children and adolescents who are involved with religious and spiritual communities. And in one study, someone actually noted that the decline of religious affiliation is actually a cause for national health concerns. And I thought that was quite interesting to put it in that way. Next slide, please. In adolescence, it's really important to assess religion and spirituality as well, because we may not necessarily think of that group as particularly religious and spiritual, but of course, just like other patients, they do know spiritual and religious struggle, particularly in the area of depression and anxiety. It is very important to assess. And the rates of religious and spiritual struggle were close to 90% in this study. So there are significant associations between religious and spiritual struggle, depression, and anxiety. I thought those numbers were quite staggering. Next one, next slide. This is a study with LGBTQ youth. They, of course, are more at risk for depression, substance use, and other mental health issues. LGBTQ adolescents have a twice as high suicide risk. This is probably even more increased when parents are not supportive of their sexual identity or gender expression. There's bias-related victimization and overall minority stress. Family dynamics can play a role, and religious spiritual struggle or exclusion, cultural clashes in values are quite prevalent in this group. Next slide, please. Now, I was, of course, in the context of my work with Eileen, quite curious about victims of clergy sexual abuse. And quite interestingly, less than 10% reported support from their congregation. About 50% were blamed for the abuse and ultimately ignored. And faith in God was most salient, however, in survivors' healing. And that was actually my impression from Eileen as well when I finally met her. Next slide. So Eileen actually requested a spiritual care consult. And the social worker and I decided that we would meet together with Eileen. And this was an incredible meeting in which Eileen talked a bit more about her religious and spiritual struggles, which were, on the one hand, understandably interpersonal. There were some differences in her faith from her parents, which was really hard for her to express, but definitely the spiritual religious struggle based on the clergy sex abuse. She also experienced some moral religious and spiritual struggle because she had felt that she had not done what she needed to do in her life, and she was to blame for some of the ways in which she was struggling due to her behavior. So her sense of demons were really related to her sense of past immoral behavior. What I could bring was an understanding of her religious and spiritual background, her community, which was both culturally and religiously quite formed by her religious background, also a sense of connection, reassurance of God's love, presence, and a positive sense of power related to religion and spirituality. And it was really quite interesting. At the end of our meeting, the social worker turned to me and said, I have never seen Eileen as calm and as relaxed as in this meeting. And I concluded that her faith was really a very important resource for her as she was trying to cope with her multiple mental health struggles. Next slide, please. So in terms of perceptions of care, patients actually rated quite positively chaplaincy care. 39% felt that it helped their coping. 21% had a sense of being affirmed in their human dignity and even having some of their struggles being normalized, which is just such a relief in an environment where a person is constantly diagnosed. 58% drew a sense of comfort and hope from chaplaincy care. 54% felt that there was an important discussion of cultural and spiritual issues that happened, and even just information that was shared. I would add psychospiritual education is an important part of what we do as well. Access to religious practices, 44%, counseling, 37%, and meaning making and focusing on values, 10%. So patients felt that their needs were not met, 48%. And this was in contrast to staff who felt that overwhelmingly patients' needs were met. So only 40% of staff in these studies said that patients' needs were not met. Next slide, please. So the benefits of chaplaincy are, first of all, meeting faith-specific needs, sacraments, dietary needs, sacred scripture, especially. In Eileen's case, it was about communion, and it was such an important piece of her recovery. Determining whether a specific belief or practice is culturally or religiously appropriate or pathologic. So while there was some misunderstanding about exorcism, and one could argue even from a Roman Catholic perspective that all the processes were not, the family had not followed all the processes that the diocese had set up, it was still appropriate to think about exorcism in this case coming from a Roman Catholic background. Benefits of chaplaincy care for patients were also in providing expertise in discussing death and loss, in building bridges to spiritual and religious communities, and therefore decreasing a sense of alienation, diminishing guilt feelings, also in patients who feel punished by God, facilitating spirituality groups, which of course also promotes a sense of community within the hospital, connecting with patient or family members who are skeptical of mental health professionals, and then lastly, helping with loss of autonomy and frustrations with the mental health system. Next slide, please. What clinicians need to be aware of? Well, so back to FICA, it would be really important to use that, and that in some ways the stigma goes both ways in the mental health context. On the one hand, in religious communities, there's stigma still about mental illness, and on the other hand, in the clinical environment, there's stigma about religion and spirituality. Yet spiritual and religious coping is complex, and we think anyhow that neglect of religious and spiritual experiences is not advisable. And there are multiple policy documents that advocate internationally for the inclusion of religion, spirituality, and cultural worldviews, for example, by the APA. Next slide, please. Specifically in my context, and I'm so grateful to stand on the shoulders of David Rosmarin, who has done an incredible amount of research in the area of spirituality and mental health, and has also developed some tools for research in this area. So according to his study in 2015, patients in my context, more than half of them reported fairly or greater interest in the integration of spirituality into psychotherapy. That, of course, doesn't always translate to a chaplaincy visit, and yet that's quite significant for the Northeast of the United States. I would assume that in other contexts, the numbers would be even higher. In my context, the rates of chaplaincy visits are between 15 and 22% of all inpatients, a little less in partial and residential program. And the chaplaincy service depends on team referrals, and collaboration, while rare, is really now more of a regular occurrence when a particular mental health diagnosis and prognosis is particularly difficult and complex, and religious and spiritual issues are part of that. Next slide, please. So chaplaincy interventions, we all know those very well. Reflective listening, which really creates community in the moment, spiritual history taking, and particularly in depth. Patients may not always speak about their spiritual history, and it's important to actively assess for that, including assessing for spiritual religious struggle. Prayer, meditation, chanting, confession, absolution, and forgiveness, which is a big topic in mental health, spiritual religious teaching, spiritual direction, 12-step spirituality. Next slide, please. So what does mental health chaplaincy add? Definitely helps in gaining perspective, which is so true in almost any chaplaincy interaction, but I think it's even more important in mental health contexts. An opportunity to process experiences, which of course not all people with severe mental illness are able to do. So even to assess whether a person is able to process or not is an important first step. And that's also a door into collaboration with the team. Reflecting on the treatment received, discussing life and role changes, stimulating connection and communication with others, reframing, particularly suggesting spiritual behaviors. So cognitive behavioral therapy is a wonderful resource for chaplaincy interventions. And then building bridges to the religious and spiritual communities, and to do that with intention and deliberation, sort of careful and at the tempo that the patient is comfortable with. And then, of course, rituals, both religious rituals as well as broadly spiritual rituals as well. Next slide, please. So what are rituals? Purposeful actions that symbolize ideas, thoughts, myths, beliefs. They connect us with something beyond ourselves, help us find peace of mind and centeredness, and offer forgiveness from guilt, closure in grief, and resilience. And particularly, I'm aware that mental health patients are so open to receiving small tokens of that can stand for an idea or symbolize a belief or a myth, or can help with closure in grief. Next slide, please. So the clinical recommendations then are that within the context, which of course needs to be considered, both the context of the behavioral health unit or the psychiatric unit, as well as the clinical context, the severity of the mental illness, there should be spiritual screening. Staff needs to continuously be educated and made aware. Often that also happens through staff care. There needs to be much more training in mental health for chaplains, and we need to also strategize to make sure that if there were any potential harm, or if staff notices anything that may not have been particularly helpful, that we have mitigation strategies. Next slide, please. So research is needed, very much. That's the refrain for so many chaplaincy presentations. What are the conditions and the patient populations where chaplains can be most helpful? We know that in the area of anxiety and depression, we can really make a big difference. But what do we know about the timing? And what about other patient populations? What does it mean to be integrated into the psychiatric team? Most of us are likely to be more of a consultant who comes in and communicates with the team and then steps out again. Does chaplaincy contribute to overall improved outcomes? And how would we find out about that? Who is the best professional to intervene? Under which circumstances? So what's the difference between a chaplain offering a cognitive behavioral spirituality group or a clinician who does the same? We do have some data where it's actually the outcome was there, or the results showed that mental health providers would be actually more welcome to offer a group like that. So what is the difference here, and how can we use the difference to help achieve the outcomes that only specific clinicians can achieve? And then what are best practices in mental health training for clergy? I believe this is the last slide, but let's see. Is there one more? Okay, all right. Thank you for your attention to this presentation, and I hope it's helpful to people.
Thank you, Angelika, for your presentation. I really enjoyed the integration of research, chaplaincy practice, also looking at a real-life case that often helps us connect those dots and integrate that into our practice. I'm looking at the question answers. I don't see many questions from the audience. I do have a few questions, maybe just for some further reflections. As one of the recurring themes is working with a team, and some of the perceptions clinicians may hold about religion, spirituality, and the work of the chaplain, or even misconceptions or not knowing what we do. What were some of your years of working at McLean and in other settings, but especially in mental health setting? What has been helpful in your work to connect with teams and then move towards collaboration, integration? What were some of those opportunities, some of the barriers that you had to overcome?
I actually was very, very lucky. I did not have to overcome very big barriers. I want you to know I have felt very, very welcome here at McLean Hospital, because there is an incredible understanding of the benefits of spirituality and spiritual care, largely due to Dr. David Rosmarin's work. But I will say that whenever I orient students to a unit, and in my own practice as well, I join the team. I cannot be a part of every team on every unit. We have 12 inpatient units, and there are 3 teams on each unit. So it's impossible to be an integrated member of that team. But I can regularly rotate through the teams. And I ask my students to initially simply join the team and listen and learn about the difference between severe mental illness and maybe a chaplain's understanding or a layperson's understanding of what depression and anxiety might look like. There's also such a cultural trend to use symptoms and diagnoses in a more colloquial way that can really be a barrier to the chaplain integrating into the team. So we need to understand how sick our patients are. And I think when we can communicate that understanding to the team, and understand to adjust our glasses and really know that we need the magnifying glass to look at what a potential outcome of an interaction was, then we are able to communicate that outcome to the team right away. So I very much believe that a chaplaincy intervention or a spiritual care conversation is not complete unless the caregiver has made a connection with the team in person at the time of the visit. Now, that doesn't always happen, but if it were to happen more often, it would be wonderful. Luckily, in our context, we are able to use narrative notes in EPIC as well. And my experience is that the teams read those notes very carefully because, of course, the 3 key items, affect, behavior, and cognition, are important. And as long as we bring observations about affect, behavior, and cognition in our notes, they're relevant for care. Mm-hmm. And therefore, people will read them.
Yeah. And then clinical communication also accumulates to more and more understanding and appreciation of what we bring to the table and how that relates back to the clinical team's work. And on the other side of you have a CP program, so you have people who are new to the setting and new to working in a psychiatric setting. Mm-hmm. How do you help them kind of start understanding how to assess and discern when and how their chaplaincy care is helpful in different situations with psychiatric patients. Kind of understanding what they can add to the care, or how to get involved in care of individuals.
Right. Yeah. Thank you for that question. That's a really good one. I think listening and validating without diagnosing is an incredibly valuable gift. So that human connection is so important, and that by itself, and really bringing dignity to a person who is in a context and is in a state of mind that is scary to them, is very, very important. But then also just opening up and being non-judgmental and being aware of the mental health issues, though, and informed about that, and to truly understand the whole of the situation of a patient is an incredible gift. And then to bring into that a piece of the patient's spirituality or religion that connects can be an incredible gift. Like, for example, for Eileen, right? I mean, for her to connect grounding exercises to her Roman Catholic faith was key in her recovery, and it helped her draw on a resource that she had, but clinicians weren't able to do that.
And along those lines, I wonder whether people who might be new to chaplaincy or have been in the chaplain settings for a while, and they may feel hesitant about engaging, because wherever we go in chaplaincy setting, we're going to encounter persons with mental health struggles, mental health conditions. What are some of your recommendations for chaplains who might feel hesitant about engaging those issues, or trying to start that integration process in a psychiatric unit at their hospital, or just in general units engaging with mental health conditions and issues?
Right. Well, good Lord, this could be a whole other presentation. I just want to say, the stigma is just incredibly high. And so we need to assess ourselves. What is the level of stigma that we bring and bias that we bring to people who struggle with a psychotic illness, a substance use disorder, even depression or anxiety, or with personality disorders. And we need to understand that it's actually our failure just as much as we are doing work in other areas. There's a kind of ableism that may get in the way of chaplains' effectiveness. Many patients struggling with mental health issues and with severe mental illness are disabled. And so in some ways, it's almost ableism if we are not open to those persons and their struggle. I would think that training is very, very important, and really truly understanding, and then learning from the patient. A patient might lead with, and I tell my students this, a patient might lead by saying, well, I struggle with depression, or I struggle with bipolar affective disorder 1. And I always say to them, I don't know what that means. I'm the chaplain. I have no idea what that means. What is it like to be you today? And the patient will tell me, and that's how you build your own diagnostic tool. That's how you build over time your own skill in diagnosing and understanding where people are. I just want to also comment, at the risk of talking too much, but I just want to comment as well that about 40 to 50% of our general medical and surgical patients have co-occurring psychiatric disorders, and they're not being treated, right? So someone struggling with schizophrenia who also carries a diagnosis of advanced cancer really needs that support for their mental illness as well, and isn't necessarily in the hospital for that kind of treatment.
And I hope that's a takeaway from your presentations and for this entire week. The theme of Spiritual Care Week is that the intersection of mental health and chaplaincy doesn't just occur in psychiatric settings or specialized mental health setting, but on the surgery, general oncology, every area of where we serve. And I really appreciated your putting side by side that, yes, we need to learn more about mental health diagnosis, but when a person is sitting right in front of me to inquire about what it's like for them.
Yes.
To live with that condition and experience that and validate and listen to that.
And then it's actually very similar to what we do, right? We elicit the story of the illness and we ask about what impact it has had. And it's very similar then. Just one word too. I mean, it's intentional that I'm thinking, I don't know, but I would think that it is intentional that Spiritual Care Week focuses on mental health this year, because we have come through some things over the last years, both individually and communally and globally, and we're still in the midst of that. We're currently seeing how people are traumatized in other areas of the world and not just one or two. And it's really important for us to understand that all those events have impact on mental health. The mental health surge is real and it's there. And we need to be trained as chaplains to address it.
And after this presentation, and maybe there are presentations this week, if there are chaplains who would like to start that learning process, do you have any recommendations for where to go, where to learn more about, or mental health and chaplaincy and spirituality resources or readings that you would recommend to start?
I mean, I think that the Mental Health Chaplaincy Network will be a next step to bring people in and to familiarize more people with the research and maybe even think of their own. I also think there are many other venues of learning. NAMI has resources for clergy to learn about spirituality and mental health, and even first aid, spiritual, psychiatric. So on that overlap, I'm sorry, I'm blanking on the actual
mental health
name.
first aid.
Yes, exactly, yeah. Mental health first aid. And that's a very important resource. And I'm happy to come and speak to CPE programs if that is something that people would be interested in.
Thank you for that offer. And then just kind of looking at the whole trajectory of becoming a chaplain and learning about these things in the CPE program and throughout our careers, how to best integrate and be mental health informed chaplains and practice, have that practice. I think I'm just looking at, we have 2 more minutes left. I did really appreciate the way that you incorporated relevant research findings that informed your understanding your role as a chaplain in psychiatric setting, as well as the care for your care recipients. And you listed a lot of different areas where research is needed. If you would have all the resources and time, where would you start? What would be the kind of the first part of this research you would explore?
That's a great question. I don't know. I think I'd be very curious to design an actual scripted intervention, because so much of therapeutic intervention, so many modalities really draw on scripted, almost scripted interventions. And I'd like to then see what the outcome is.
Yeah. And as you mentioned, what is the outcome and effectiveness unique to chaplains doing that intervention and chaplaincy care?
Right. Well, and then additionally, I think spiritual struggle is so prevalent. And do we actually ask about it, or do we feel like we're inducing it by asking?
That's a great
question. May or may not come up, right? I mean, we know from palliative care that sometimes chaplains don't ask the question, but we should. this is what we do.
And I think that's a great way to end the presentation as well. This is what we do, and you presented many different ways to expand our practice today. I appreciate you sharing your wisdom, as well as you being the co-convener for the new research network, and hope to continue these conversations with you and others in this space. And for those of you on the call, please consider our webinars for the next few days as well, further exploring this topic. And thank you for being here today. Thank you, Angelika.
Thank you.
I think we are offline. So thank you so much, Angelika, for doing this, and really enjoy the presentation.
Oh my goodness, it's it's you probably can appreciate that I